Kalimera, Kalispera. I'm Roxana Moran from New York, and I'm really honored to be here with you today in the IGIA conference to talk to you about the patient-centered selection of antiplatelet treatment in acute coronary syndromes and PCI. Important for you to note my disclosures. Antiplatelet therapy is the cornerstone of what we do after a percutaneous coronary intervention, whether it's an acute or a chronic coronary syndrome. And obviously, importantly, this is to reduce thrombus burden and flow obstruction, reduce peri-procedural damage, and prevent stent thrombosis. But in order to best figure out what to do when balancing of bleeding and ischemic events, when we do this and anytime we use them, we have the hazard of bleeding. We need to understand the timing of bleeding and ischemic events. And there are three kinds of ischemic events, those local stent-related events that are very rich in that first 3 months, but dissipate over time. The plaque progression and destabilization that are still pretty prevalent in those first 3 months, but continue to be building up over time. And then the systemic ischemic events, peripheral and cerebrovascular events that are, again, a constant. Very similarly, bleeding events are also constant throughout, most prevalent around the time of PCI in the first 3 months, but also throughout the follow-up period up to 36 months. Our job as clinicians is to find the best possible scenario for our patients, the sweet spot of the lowest ischemic and bleeding events, and how do we do that? And in order to do this, we're looking for a tailored approach for our patients. And this requires risk stratification and personalization of antiplatelet strategies after PCI by using clinical procedural variables, some scores that identifies the risk of bleeding and ischemic events, very importantly, some of the important platelet function testing and genetic testing to help us guide therapy. And on all fronts, whether it's bleeding or ischemic events, there's a lot of overlap. And I think it's very important to note that in stable, unstable, and ST segment elevation acute coronary syndromes, for the most part, dual antiplatelet therapies still play an important role from 6 to 12 months, but tailoring that has to do with understanding all of these aspects and understanding where the patient fits. And the fact is that over the last 3 decades, we've been somewhat confused in terms of prolonging, shortening, or stabilizing the antiplatelet regimens. And I think where we are today is a period of equipoise, where we have safer stent platforms, more nuanced understanding of DAPT cessation, and novel approaches like a short duration of DAPT and a P2Y12 monotherapy, and important de-escalation. So let me talk about some of these novel strategies, a case-by-case selection of antiplatelet therapies. Let's begin with P2Y12 monotherapy. Just today, the FDA approved ticagrelor monotherapy after a short duration of DAPT for acute coronary syndrome patients. I think this is very important. The rationale for withdrawing aspirin after PCI is very clear. Aspirin causes bleeding, GI and extra and intracranial bleeds. And the fact of the matter is that we haven't really been able to show important benefit in reducing ischemic events in presence of potent agents like ticagrelor or prasugrel. And as a result, there have been several studies that have been working to drop aspirin and move into a shorter duration of dual antiplatelet therapies and moving towards a monotherapy with these potent agents. And we have this with global leaders at the head, but Twilight is the only double-blind placebo-controlled trial. And then, of course, Tyco and StopDapt. And just this past ACC, we heard more data on even shorter duration of DAPT with ticagrelor. The Twilight trial was the trial that I think broke the mold. We presented this in 2019. Unbelievable that it was already 5 years ago. And these were high-risk patients who got into an open enrollment period with aspirin and ticagrelor. And then if they were event-free, they were randomized to ticagrelor plus aspirin versus ticagrelor plus a matching placebo, and then followed for 12 months for evaluation of ischemic and bleeding events. And as you remember and recall, there was a major reduction in bleeding, both in BARC 2, 3, and 5 bleeding, but also BARC 3 and 5 bleeding, and absolutely no differences in the key secondary outcome of death, MI, stroke, or in that very, very hard endpoint with over 7,119 patients included. So you might come out and say, well, is this for everyone? What about ACS, complex PCI, diabetics? These people have a lot more ischemic events. And then, of course, we have the elderly, chronic kidney disease, women, high bleeding risk, and oral anticoagulation when there's a more bleeding issue. Where does this fit? Well, let me tell you that in the ACS, Twilight ACS program, where over 4,000 patients were randomized, 4,400 patients were randomized to this therapy, there was a very, very good similar benefit shown for a P2Y12 monotherapy in reducing with ticagrelor in reducing ischemic events, reducing bleeding events without increasing ischemic events. And very importantly, in complex PCI and high bleeding risk patients, we also found that especially in high bleeding risk patients, that the degree of reduction of bleeding was that much more increased in those patients, as well as very important, no change in the ischemic events. Furthermore, in complex PCI, we again saw significant reduction in bleeding events without increasing ischemic events. So this was really, really very, very important. We also were part of an IPD meta-analysis of over 24,000 patients where P2Y12 monotherapy after a short period of DAPT in complex patients in the Sydney 2 IPD was shown to show a reduction of bleeding as well as net adverse clinical events with no differences in the primary endpoint of death MI CVA. Very, very important. But is it for everyone? As you all remember, the STOP-DAPT-2 ACS failed to reach the non-inferiority for clopidogrel monotherapy. And I think this is very, very important to evaluate that in these patients who received aspirin clopidogrel versus clopidogrel monotherapy. And then in STOP-DAPT-3, where they also examined prasugrel, then de-escalated to clopidogrel compared to prasugrel to aspirin, they really were not able to show the non-inferiority. They failed the non-inferiority, unfortunately. And then in Sydney 3, ticagrelor monotherapy versus DAPT actually shows no change in the primary endpoint of ischemic events and a major, major reduction in bleeding. So you could see that it's quite effective. Clopidogrel monotherapy, also in the Sydney 3, you see that dual antiplatelet therapy had the primary endpoint compared to clopidogrel monotherapy was more obviously less effective than it was in terms of the ticagrelor. So very, very important here, clopidogrel monotherapy compared to DAPT was not as good, but bleeding again was better for clopidogrel monotherapy. De-escalation strategies are also very, very important to evaluate. These are the ways to de-escalate, and you could de-escalate by reducing the dose or stopping a therapy or changing a therapy or dropping one of them. And I think it's very, very important that if you look at what's going on with genetic testing or reducing the dose or downgrading to a clopidogrel from a potent agent, I think it's all part of a de-escalation. In ACS, an individual patient data meta-analysis of all of these trials, tropical ACS, popular genetics, host reduced, Talos MI, over 10,000 patients, what you see very, very interestingly is a reduction of the of cardiovascular, death, MI, cerebrovascular events, and also a reduction of bleeding with de-escalation in acute coronary syndromes. And I think what you're seeing favoring de-escalation is a very better way of perhaps managing these patients instead of just the short duration of DAPT. Chronic maintenance is another very important study, and this was the host exam study that I think is beginning to make us question whether or not the long-term aspirin for monotherapy forever should be replaced with clopidogrel, because here in over 5,500 patients, they showed a benefit for clopidogrel monotherapy as the chronic maintenance after dual antiplatelet therapy for PCI compared to aspirin in a net adverse clinical events in favor of clopidogrel monotherapy for this very all-inclusive, all-cause mortality, non-fatal MI, stroke, readmission to ACS, and major BARC3 or more bleeding. And I think what you're seeing here for long-term maintenance, most of it driven by the host exam study, that the P2Y12 monotherapy could be safe and effective, and as a standalone secondary prevention as compared to aspirin alone. But this needs a prospective trial, and I think this is an absolute unmet need for us to better understand. Last but not least is this dual pathway inhibition. This is important because despite everything we've done, we still have residual events, and that we know that there is a synergistic inhibition of the two essential components of factor 10A with thrombin inhibitors and P2Y12 inhibitors with platelets on the platelet pathway. And COMPASS, the COMPASS-like strategy with combining a P2Y12 therapy with a factor 10A showed a very, very important benefit of rivaroxaban 2.5 milligrams BID with aspirin, and of course with a background of clopidogrel. This dual pathway inhibition is advantageous in combination of SAPT in high bleeding risk patients at high ischemic risk like polyvascular disease. But is it ever possible to uncouple hemostasis and thrombosis? And I think this is really the next level of where we're going with factor 11 inhibition, because we have the heparins, the VKAs, and all of these are using the intrinsic thrombosis pathway, but the hemostasis pathway is quite affected as well. But if you go to factor 11, when you're going a little bit more upstream and you're not meeting in that place where these two are meeting, you might have better hemostasis. And I think that this uncoupling of the factor 10A inhibition, when it is used, amplification of thrombin is inhibited, prevents the pathological thrombi, but the tissue factor pathway still produces thrombin, which allows for beneficial blood clots. We know that human genetic deficient patients with factor 11 actually enjoy the benefit of reduced risk of thrombosis and rarely experience a spontaneous bleed. And the genetic epidemiology has shown in large cohort studies that the risk of thrombosis is twofold higher in patients who have higher factor 11 compared to those have normal. And I think this is very, very interesting, and a lot lower in those patients who are deficient in factor 11. And animal studies also show that factor 11 inhibition attenuates thrombosis in mouse, rabbit, monkey, baboon models, and there's no increase in bleeding. And as a result, we have a massive program out there with different technologies that include small molecules, antibodies, and aptamers, and I think it's going to be very, very interesting. You all know about the asundexian program. This is a factor 11. This was used in Pacific AMI in 1,600 patients, where there was a reduction of bleeding. The death MI CVA was no difference, but the safety needed to be evaluated in a much larger studies. But we know that at the moment, the Librexia study has over 50,000 patients there. So we are really, really excited about factor 11 inhibition that's targeting that residual thrombotic risk without increasing bleeding. Several studies now with whether it's VTE prophylaxis, whether it's atrial fibrillation or after stroke or after an MI. And we're seeing a very, very large number of studies being done. And of course, importantly, in the aspirin-free strategies, we are looking to find a way to reduce bleeding without increasing ischemic harm. And that is exactly what we're doing with P2Y12 monotherapy, especially in those patients who are at a high bleeding and thrombotic risk. And these patients would very, very much benefit this important combination. I hope that I was able to put this together in a good way for you. I appreciate being invited to IGIA, and I can't wait to see you all in person in my home country, Greece. Many, many, many thanks. Ευχαριστώ πάρα πολύ. Γεια.